ये तो मेरे को चाहिए था।
इसका चादर चाहिए
ना चलो वही है वैसे सब। ओके मैंने चाहिए माइक रखो या श्योर सर मैं हर बार भूल जाता हूँ। हाँ ये ठीक है।
चलो सो ये लाइव
सर मैं बैठा हूँ
Yeah,
खड़े,
sir,
अच्छा नहीं
will-
लग रहा
sir,
बैठे।
so we'll be sharing the PPT soon. Clear?
These are the PPT as well as the PDF. You don't have to worry about that.
सब मिलेगा
थोड़ा सा ब्लैक
ना वो इसलिए क्योंकि इसकी स्पीड वहां से कम है, हमें कुछ नहीं करना, वो अपने आप क्लियर हो जाएगा। ये क्या होता है ना, डिपेंडिंग ऑन द नेट स्पीड, जो बंदे की स्पीड कम है, अपनी स्पीड ऐसी आ रही है।
राइट सर।
कोई दिक्कत मैं उसको पेमेंट कर
Hey Shivu, I'll choose a new page. ये रहा जी। Right guys, can we start? बच्चों का जवाब चैट ये रहा। ओके दिस इज फाइन, बिकॉज उसमें अपने वाले में तो चैट में जाना पड़ता था, पर इसमें थोड़ा सा हल्का सा लैग। Since they're not liking this.
ना
अरे उसका वो तो रख दो, मुझे शफल करना है जैसे उसके बीच में, तो मैं ऐसे शफल करूं। इसका आपने वो रखा हुआ होता था ना कीबोर्ड, हाँ तो ऑल टैब से मैं शफल कर लूंगा ना। ये मेरा फोन हटा दीजिए बेशक, इसकी जरूरत नहीं है मुझे, इसको पीछे रख दो साइलेंट पे ही आज।
कुछ कीबोर्ड के चाहिए तो यार
सर
आई
हाँ
थिंक एवरीथिंग इज फाइन।
जी सर जी एग्जैक्टली। नो सर लिख के
आई थिंक सर विल स्टार्ट।
ये ठीक है सर ऐसा।
सर वो तो आपके कंफर्ट के
सर ये सब तो चलता है। Right, so kindly allow me to start. Now this is also quick and concise class on the topic of breast. Fine. So we'll be discussing the surgical anatomy, we'll be discussing the surgical topics, we'll be discussing the benign tumors, malignant tumors, different benign conditions of the breast. Fine. I hope everything is okay. We are audible clearly and the screen is clear to you. Dr. Saab, may I know your name? May I know your real name, please? Dr. Shah will definitely will send the PPT, will definitely will send the PDF. You don't have to worry about that.
ठीक है, अभी थोड़े और आना दो सर, क्योंकि चक्कर क्या है ना, मैंने कहा था क्लास डिले करेंगे ना,
हाँ।
तो इसलिए कई बच्चे थोड़ा लेट आएंगे।
Sir,
तो वन डे 200 यू स्टार्ट, तब तक आप ऐसे
right, sir, right.
बहुत गाने गा दे मैं सर।
कल आप एक्चुअली बहुत अच्छा गाए थे। Quick, concise topic of breast. Let me just elaborate what kind of topic we'll be reading. First, we'll see what is the concise anatomy of the breast. Fine. Then we'll be reading the benign disorders. That includes ND, aberration in normal development and involution. We'll be studying fibroadenoma. We'll be studying fibroadenosis. Fine. Then we'll be studying sclerosing adenosis. That includes the breast cyst. Fine. We'll be studying duct papilloma. Fine. Mondor disease. Right. And then the mother of all topic, the carcinoma breast. Then we'll see the investigation related to the breast. For example, we'll be reading about the mammography, we'll be reading about the ultrasound, we'll be reading about the MRI. Fine. Then the surgical management, breast reconstruction. Fine. That all we'll be reading. Fine. So I hope we are good to go now, or shall we wait? Actually, I started from my place at around 6:30, but then there was so much traffic. Suddenly there was like flash rains. Flash rains were there, so that delayed my journey. I mean, I could not reach here on time. Fine. I was supposed to be more late, but then probably I reached on time. I reached just on time. right? So we'll seek permission from sir before we start. Dr. Shaul, Dr. Kushal Rathor, am I audible clearly? Is there any kind of lag you're noticing? It says 183 students are watching, but they are not replying to any of my words. So please do let me know whether I'm audible clearly or not. You can send live chat. Just a minute, guys. Right, so kindly allow me to start. Kindly allow me to start. So, now you see what are breasts. So, breast, you see, they are modified sweat glands, modified sweat glands. Fine. Now they lie over the chest. They lie over the chest. Now you see what question they might ask you. What question they might ask you? They might ask you about the vertical extent of the breast. So it will extend from second rib to the sixth rib. Second rib to the sixth rib. Fine. Now they might also ask you about the horizontal extent. So you see it extends from the lateral border of the sternum, and it may even extend up to the mid axillary line, fine, mid axillary line. Now you see three of the hormones, they act on the breast when we talk about the physiology. So estrogen will cause duct proliferation, progesterone will help the lobular proliferation, fine, and prolactin will cause the milk secretion, Okay, I thought that I could not see your messages there. That is why I was like worried that why are you guys not replying at all? I'm sorry, I could not check. And thank you, Asif. It's actually heartening to listen to you. Wow. Thank you. Probably it did not refresh itself. So that's why I'm sorry. Thank you, Adbharat. Okay, so now I know, because now I know that you can listen to me. So my humble request, please, let's make good use of this time. So please don't forget to send your queries. Prolactin, milk secretion. Okay. So if you want to be, technically correct, let's say we call it milk production. Yeah. Thank you, Sunanda. Same here. So prolactin, milk production. You see, that's why I say that keep on asking your queries. Now you see, what is this? The axillary tail of the breast. I told you that the entire breast lies in the superficial fascia because it has sweat glands. It is made up of modified sweat glands. Only this part, the axillary process, we call it as axillary tail of Spence. It lies into the deep fascia. You see everything you can see over here on the right side, that lies in superficial fascia. Thank you, buddy. Thank you. And you see, it will penetrate the foramen of Langer, and then it will enter into the deep fascia. Fine. Now, so what they might ask you is that axillary tail of Spence. So it lies in deep fascia. Fine. Lies in deep fascia. Now, again, the next thing there about the axillary tail of Spence, that it will pierce the foramen of Langer. What is the clinical significance? What is the clinical significance of axillary tail of Spence? That it might be mistaken for a group of lymph nodes. Fine. Now, another thing significant in the anatomy, that let's say this is the skin. Fine. This is the pectoral fascia. Fine. So this skin and pectoral fascia, they are attached to each other by ligament of Cooper. Fine. Ligament of Cooper. Fine. Now, the problem is that cancer cell may grow along these ligaments. That is a problem with the ligament of Cooper. Fine. So, moving on to the next thing, let me just show you there. So, you see here, breast is made up of these structure called ducts, and then it is made up of lobules. It is made up of lobules. Fine. Now, so several lobules, they make up terminal duct lobular unit. Terminal duct lobular unit. So, this terminal duct lobular unit, this happens to be the functional unit of breast. Terminal duct lobular unit. So, this can be asked as a one-liner. Terminal duct. I'm really sorry. I'm generally trying to improve my handwriting, but naturally, with the little luck. So, terminal duct lobular unit is the functional unit of breast. Is the functional unit of breast. Just a second. Right. Okay. Now, the most important thing there, most important thing in the anatomy, see, when I take regular class, I discuss them with the carcinoma, but because ours is a concise class, let's discuss them here only. Fine. You see, main topic in the topic of breast is the topic of carcinoma. So when we are discussing carcinoma, naturally, we have to discuss the lymph nodes also. Fine. So you see, 75% of the lymph node drainage, it goes to the axillary lymph nodes, Fine. So 25% of the lymph node drainage will go to the internal mammary lymph nodes. So these are the simple question which they might ask. Fine. Now, all the lymphatic drainage of the breast, it starts from Sappi's plexus, which lies below the skin, that is subdermal plexus. Now you see here what they might ask you in the topic of lymph nodes, See, axillary group of lymph nodes. The word is group of lymph nodes. So you see, there are 5 groups. Fine. And they are divided into 3 levels. Fine. So I request all your eyes on the screen there. You see here, let's say this is the pectoralis minor muscle. Consider this pen to be the pectoralis minor muscle. All the lymph node below this level will be level 1. All the lymph nodes which are behind the pectoralis minor muscle will be level 2. And all the lymph nodes which are above and medial to the pectoralis minor, that will be level 3 lymph nodes. Now when you have seen this on the screen, let's see this on the image also. Fine. Now you see, pectoralis minor is connected to coracoid process. You can see by yourself. Let me draw this. Fine. So that at least you can see it clearly. Fine. Let me draw this. Now, you can clearly see this. We are discussing the levels. You can clearly see that the lymph nodes which are below and lateral to the pectoralis minor, fine, those lymph nodes are level 1 lymph nodes. Another thing which you can see over here, lymph nodes which are exactly behind the pectoralis minor muscle, Fine. These lymph nodes are level 2 lymph nodes. The third thing which you might see over here, the lymph nodes which are above and medial to the level 2 lymph nodes. Fine. They are level 3 lymph nodes. Level 3 lymph nodes. And then later you can see all these lymph nodes, they drain to supraclavicular lymph nodes. Supraclavicular lymph nodes. Supraclavicular lymph nodes. Fine. I want to see you one more image there. Let me just show you there, because I told you we discussed this along with the topic of carcinoma. Fine. And breast happens to be a very long topic there. Very long topic there. See, here in the image you can see we are discussing the level. We are discussing the level. So you see these green lymph nodes here. They are level 1 lymph nodes. The one which are behind the pectoralis minor, they are level 2 lymph nodes. And the one which are above and medial to the pectoralis minor, they are level 3 lymph nodes. Pallavi, Pooja, beta, all the lymphatics, see, Sapis plexus, I'm glad you're asking queries. I'm actually glad that you're asking queries. Let's say this is the breast, fine. And let's say there is a tumor over here, fine. So this tumor will first of all enter the lymphatic plexus, below the skin, fine. Lymphatic plexus. See, when I say Sapis plexus means group of small vessels. So try to understand, if there is a tumor in the breast, that tumor will first of all enter into the subdermal lymphatic vessels. From there, it will go to the lymph node. Mango Shake, I'm really sorry, I'm calling you by name. Mango Shake, Dr. Rahul. The question which they ask is about the levels involved. Question which they ask is about the staging of the tumor involved. Fine, that is what they asked. Let me just change my seat, because I'm covering large part of the screen, I believe. Fine. Yes, I was. This is what happens when you gain weight. Right. So coming back to the axillary group of lymph node, you see here we have 5 groups and 3 levels. Fine. So you see axillary group of lymph node, the mnemonic is PALAK. Fine. Now, PAL, group 1. Fine. Now, C, group 2. A is group 3. Fine. A is group 3. Fine. Lymph node. So you see here, let's study important lymph nodes there. First, we'll study the level 1 lymph nodes. So then, first one is anterior. Fine. Like this. What you got to see over here? When you stand like this, axilla has the anterior axillary fold. Fine. Now, anterior group of lymph node. They are also called as pectoral. They are also called as external mammary group of lymph node. What? They are most commonly involved. Those of you who want quick revision, naturally will do quick revision. Fine. But then, because this is an important topic, we will spend some time over here. So posterior, they are also called as subscapular. Then is the lateral group of lymph node. So they are found along axillary vein. So that is like PAL. From the PALAK, we chose this. PAL. Now we'll go to the C, central. So this forms the level 2 lymph node, central. See, In the regular class, I'll keep on asking that if you did not understand, I'll repeat it n number of times. I will repeat it because this is a concise class. So we may not be able to repeat the points many a times, but if you still did not understand, do let me know. I'll try my level best to adjust the time. Fine. Okay, central group of lymph nodes, fine. So they are rarely involved, but once they are involved, your patient has poor prognosis. And the third, level 3 is the apical group of lymph nodes, apical group of lymph node. And I told you later, they all drain into supraclavicular lymph nodes, So if your patient has supraclavicular lymph node, that means everything is gone. Fine. The disease is extremely advanced. Fine. Now, you see here, this is probably not the correct PPT. Don't worry. Fine. Now, what is the difference there? The congenital disorder which you have to understand. Athelia. Athelia means no nipples. Polythelia means more than 2 nipples. Fine. Amasia means no breast. Fine. No breast. Make sure you no mistake that amasia is different from Poland syndrome. Why? In amasia, only thing is that breasts are not there. In Poland syndrome, even the pectoralis major muscle is not there. There is defect in the formation of pectoralis major muscle. Without wasting any time, we'll discuss now the benign disorder. So first, which we are going to discuss over here, fibroadenoma. Fibroadenoma is the most common benign tumor. Fine. In the patients who are less than 30 years of age. You see here, the most common age is 15 to 25. Most common age is 22. Okay. Panogati, definitely we'll repeat the lymph node when we're discussing the topic of carcinoma breast. I'll repeat the lymph nodes, don't worry. Fine. Most common benign tumor in the female less than 30 years of age. It is called breast mouse because it is freely mobile. Now, just say, so one kind of fibroadenoma may arise from here, second kind may arise from here. Now you see, inside of the duct, inside of the lobules is having cells. Fine. Outside is all fibrous tissue. So intracanalicular fibroadenoma is soft because it is made up from cells. Extracanalicular is hard because it is made up of fibrous tissue. The treatment is reassurance, but it is tough to convince. A female. Fine. If you are able to convince, no further management required. Surgery is done if it is more than 5 centimeters. That is, it is a giant fibroadenoma. Fine. Second, if it is causing cosmetic disfigurement. That means it is distorting the shape of the breast. It is distorting the shape of the breast. If there is rapid increase, what is the treatment? What is the incision? So either you do circumareolar, that means around the areola, or you use Gillard-Thomas. Gillard-Thomas. What is Gillard-Thomas? That is the inframammary incision. Inframammary incision. Fine. Now, so in the females who are like 25 to 30 years of age, this disease is common. Fibroadenosis. Fibroadenosis, which is also known as cyclical mastalgia with nodularity. So there are multiple small cysts in the breast, but there is one big cyst which is called as blue dome cyst of Bloodgood. That is one big cyst. Reassurance means you tell the female that there is nothing to worry about it. This swelling will never ever turn malignant. Never ever turn malignant. Fine. So the drug of choice is evening primrose oil. Drug of choice is evening primrose oil. The second drug of choice is danazol. So even though danazol is the most effective drug, fine, but problem is it will interfere with FSH and LH function, follicle stimulating hormone and luteinizing hormone, follicle stimulating hormone and luteinizing hormone. Fine. Now, so drug of choice is evening primrose oil. So we use it in the form of capsule, 1000 milligram twice a day. Second drug of choice is danazol. Now, why are we not using danazol preferentially? Because it may cause unwanted side effect like hirsutism. Yes, PDF will be available. PDF will be available. PDF will be available. Don't have to worry about it. Fine. We can also use tamoxifen. We can also use bromocriptine. Patient says that, doctor, I don't have the patience to wait for the medicines to act. What do you give then? You advise your patient the option of subcutaneous mastectomy. Subcutaneous mastectomy. What is the benefit of subcutaneous mastectomy? What question is asked? Nipple and areola are not cut. Nipple and areola are not cut. Dr. Mango Sheikh, Dr. Rahul, blue dome cyst. You say, let's say this is the breast of the patient, and this breast is having multiple hundreds of small cysts. Now suddenly you notice that there is a cyst which is very big. Fine. So this big cyst will be called as blue dome cyst. So one big cyst amongst the hundreds of cysts will be called as blue dome cyst. Blue dome cyst, right? Then the next thing here is breast cyst. Fine. Now, breast cyst is common, generally seen in the female 30 to 45 years of age. 30 to 45 years of age. Now, you see here, let's say these are the glands of young female. Fine. Now, these are the glands of female who has had menopause. Now you see, the duct is very small, the lobuli are very small, lobules are very small. Shashank beta, it is bilateral. Fine. Now this is coordinated involution. Coordinated involution. Suppose your patient unfortunately undergoes uncoordinated involution. The duct becomes very small, but the lobule remains big. Lobule remains big. Fine. What will be the problem? What will be the problem? All the cells which are shed, they will block the duct. They will block the duct. And ultimately what will happen? A big cyst will form. Big cyst will form. Fine. So how does the cyst form? How does the cyst form? So cyst forms due to uncoordinated involution. Uncoordinated involution. What is the treatment? Treatment is just aspiration. Treatment is just aspiration. You just do the aspiration and your patient definitely will be fine in no time. Fine. Now, Phyllodes tumor. Phyllodes tumor. Fine. Phyllodes tumor is also called as serocystic disease of Brody. Serocystic disease of Brody. Fine. Now it is called as cystosarcoma. Phyllodes also called as cystosarcoma phyllodes, which again is a misnomer, because sarcoma changes never happen. Sarcoma changes never happen. Never happen. Fine. Sarcoma like changes never happen. Fine. Now it is called as phyllodes because when you see this tumor on microscopy, fine, leaf like changes are seen. Leaf like changes are seen. Fine. Leaf like changes are seen. Right. That is why it is called as cystosarcoma phyllodes. Now, this is a very large tumor. Fine. Now, it may have variants. Some may be benign. Some may be locally malignant, while some of the tumors will even be metastatic. Fine. Now, what do they ask about this question is that what kind of surgery will you do? Now, you must keep in mind that lymph nodes are not involved. Fine. So you just need to do simple mastectomy. That means you will not be dealing with the lymph node. There. Fine. You won't be dealing with the lymph nodes. So that is why the treatment is simple mastectomy. No chemotherapy, no radiotherapy. Fine. Now, the next thing there is plasma cell mastitis. Fine. Now, plasma cell mastitis, see here, the pathogenesis is obscure. We don't know what causes this condition, but naturally this condition is more common in smokers. Fine. More common in smokers. So there is blockage of the lactiferous ducts. Fine. Ducts, it may arise from the ducts. Fine. Now, so what are the common presentation? Common presentation is greenish discharge. Common presentation is greenish discharge and slit like nipple retraction, slit like nipple retraction. Fine. Treatment is cone excision of the ducts. Fine. You can also do Hadfield operation. What is Hadfield operation? That is excision of all the major ducts, excision of all the major ducts. Fine. Now, next is the Mondor disease. We'll be covering every topic. We'll be covering every topic. Now, this is called as string phlebitis. String phlebitis. Ravesh, but I'm not sure whether I'll be able to answer you correctly or not, because I haven't heard of the term you're talking about. Maybe I'm less informed here, but naturally I'll send it to my WhatsApp groups, and you see here, I'll just try to answer you as early as possible. So slit like retraction will be like this. Fine. So here the nipple would have gone inside. Nipple would have gone inside like this. Fine. See, normally the nipple is like this, but here it would have gone inside because of the fibrosis. Because of the fibrosis. Fine. So Mondor disease is also known as string phlebitis. String phlebitis. What question they might ask? Which are the common vein involved? So it is the lateral thoracic vein. Treatment is warm compresses, non-steroidal anti-inflammatory drugs. Thank you, buddy. Fine. Shashank, PUD orange is a different concept. PUD orange is a totally different concept. We'll see the PUD orange when we are discussing the topic of breast. We are discussing the topic of benign disorders. Fine. When we discuss the topic of breast carcinoma, at that time we'll discuss the PUD orange. Fine. You see, you have thrown me out of the gear. So we were about to discuss this benign disorder called as duct papilloma. So you see, what they ask you is, what is the most common clinical feature of duct papilloma? It is the bloody nipple discharge. Then they ask you, what is the most common cause of bloody nipple discharge? What is the most common cause of bloody nipple discharge? In that case also the answer will be duct papilloma. Then the third question which they ask you is, what is the most common location? That is subareolar. Yes, I know. Subareolar. Fine. Most common location. So we'll discuss the images when we have. You don't have to worry about this. We'll discuss it. Don't worry. Fine. Now, the next, when our friend Kushal Rathore, I'm glad. You see here. Just a minute. If you want images, let me see what I can do here. Let me see what I can do over here. Just give me a minute. We're not using that PPT. Don't worry. We'll see what can be done. So what they might ask you here is that what kind of changes are these? What kind of changes are these? So these changes in phylloid tumor, they are due to necrosis of the skin. They are due to necrosis of the skin. They are not due to involvement of skin by the cancer. Fine. Now just give me a minute, please, because you want to have some of the images. So let me use it. The most common location is subareolar. Dr. Shabu, can you please be here with me for a minute? Can you please come to the studio? I need some PPT there because this is not the right PPT. Please. So treatment is removal by tennis racket incision. Tennis racket incision. No, Dr. M. Dr. Kushal. Please wait. I'm changing the PPT. This is not the good PPT. This is not my PPT. That is some other PPT actually. So my PPT will be available in a minute. Fine, my PPT will be available in a minute. Fine, that has got some slightly better images. Fine. Now, meanwhile, let's discuss this big topic. Let's start discussing this big topic. So this is the most common cancer in the urban women of India. Also, this is the second most common cancer causing cancer related deaths. I'll send Dr. Sabir, don't worry. Fine, I'll send. Now you see, one simple thing is this cancer will occur in the breast which have been denied their function, Just compare the curious case of two females. Let's say this female, let's call her female A. This female marries at 20 years of age. Fine. So you see here, when she was 10 years of age, estrogen started acting on her body. Fine. Now, suppose at 25 years of age, she has a baby. Now, what will happen? Estrogen level will drop drastically and progesterone level will rise. After a year, estrogen level will rise again. Let's say at 30 years of age, she has another baby. Estrogen level will fall again. Fine. And then they will rise after 1 year. Now, let's see what happens to the female B. Now, you see here, at 10 years of age, she attains menarche. Fine. Now, she does not marry, she does not have any babies. That means estrogen will continue to act on her breast. Sabir Rahman, I'll share, don't worry. Fine. It will continue to act on the breast. Fine. Now, so this is common if the female has early menarche and late menopause. That means the estrogen will get lot more time to act, lot more time to stimulate the breast. Fine. Dr. Shibu, can I have my own PPT actually? It is an old PPT.
Sure.
Fine. So, I'll just take my laptop. Oh, what is this orange color thing? Just give me a minute, guys. I'm just changing my PPT. It must be there only. You know, I keep on changing my PPT with every class, so. No, I gave it. Okay, let me check. Just hold my laptop. When I reached, I gave the PPT. I think I gave the PPT. I gave the pen drive. It's here, it's here, it's here. It's here. I'm changing the PPT, don't worry. You see this also. Now I want this breast PPT.
Okay, sure.
Fine. We are changing my PPT, right? Now, meanwhile, let's continue. So this is high alcohol consumption, breastfeeding. If it is done for minimum 1 year, this will be protective. Fine. Modern OCP, oral contraceptive pills, they are not a risk factor. Fine. Now, when we talk about hormone replacement therapy, which you give to the females after menopause, fine, that is a risk factor if it is used for 10 years. Hormone replacement therapy, if you use it for 10 years, this is a risk factor. Obesity can certainly be a risk factor. Why is obesity is a risk factor? Because of increased conversion. Because of increased conversion of steroid hormones to estrogen in the body fat. Fine. In the body fat. Now, someone of you just asked me about the BRCA. So, the most common gene mutation, unfortunately, it is not the BRCA, it is the P53. Why? Because 70% of the cancers, they are not familial. 70% of the cancers, they are sporadic. That means they are fresh mutation. Did you check? Okay. Now we have my own PPT, and I believe I've added certain images. So this seems to be better. Which one is this? No, there are two breasts there.
Second one.
Wait, this?
Sure.
You sure?
Yeah.
Just wait. Yeah, this is my PPT. Right. Thank you. This is my PPT. Yes. So she just came to know that estrogen causes the stimulation of the breast. Now, probably that answers all your queries. The Sapes plexus. Someone of you just asked me about the Sapes plexus. Fine. And then you see there the internal memory lymph nodes also you can see over here. The axillary lymph nodes you can also see over here. Fine. The supraclavicular lymph node also you can see over here. Now, why alcohol? Alcohol will release many free radicals. So it may cause many of the gene damages. Now, when it will cause gene damage, naturally, it will cause many tumors. It will cause the development of many tumors. Fine. Now, what they might ask you is, see, again, naturally, because this is my own PPT which we are using right now. So you see it is clearly showing the levels also. Fine. So the lymph node which are lying behind the pectoralis minor, that will be level 2. The lymph nodes which are above and medial, that will be level 3. Below and lateral to the pectoralis minor, that will be level 1. Shashank, but a most common gene mutation will be P53. I understood your point. I understood your point. See here. So 70% of the cases are sporadic. Fine. That means no family history. Up to 30% of the cases can be familial. Now, if your patient has no family history, most common gene mutation will be P53. That means 70% of the cases might have P53 gene mutation, while 30% of the cases which are familial will have BRCA1 gene mutation, Now, what are the syndromes which are associated? Lee-Fraumeni syndrome, Cowden syndrome. Fine. So there is a difference there. When you ask about the P53 and BRCA1, P53 is the most common gene mutation overall. BRCA1 is the most common gene mutation in familial cancer, Fine. Now, few words about the BRCA1. Fine. So, BRCA1 gene is present on chromosome number 7. Cancers, they present at early age. They are bilateral. Yes. Shashank beta, if the family history is not mentioned, then you will go in for P53. In short, these cancers will be extremely aggressive. Fine. Now, BRCA1 gene mutation is also responsible for colon and prostate cancer. Fine. Now, when you talk about the BRCA2 gene mutation, this gene is present on chromosome number 13. So these tumors are estrogen receptor positive. Now, other cancers associated, OCP, fine, or ovary, colon, prostate, pancreas, gallbladder, stomach, and melanoma. Fine. So they are commonly associated. Now, so you see here we have four type of cancers. Let me draw each one of them. One is this. Other one is this. The third one is this. The fourth one is this. Fine. So let me name each of them. This one is ductal carcinoma in situ. This one is invasive ductal carcinoma. This one is lobular carcinoma in situ. And this one is invasive lobular carcinoma. Fine. You see the difference between all of them. Ductal carcinoma in situ, invasive ductal carcinoma, lobular carcinoma in situ, and invasive lobular carcinoma. You can see the difference. Lobular carcinoma in situ is arising from the lobules, but it has not breached the basement membrane. You see here, the basement membrane is breached in the invasive lobular carcinoma. Same thing goes here. In the ductal carcinoma in situ, you see the basement membrane is not breached, whereas you see that in the invasive ductal carcinoma, the basement membrane is breached. Breast cancer has gone beyond the basement membrane. So the most common type of breast cancer is invasive ductal carcinoma, NOS. NOS is not otherwise specified, not otherwise specified. So first we'll start with the ductal carcinoma in situ. Ductal carcinoma in situ. So if we define it, it is the dysplasia which has not breached, dysplasia which has not breached the basement membrane. Dysplasia has not breached the basement membrane. I'll keep on discussing them in between. For example, in pathology, they might ask you, which gene is overexpressed. So there is high expression of CERB gene. Fine. This they might ask you in question. Yes, Mutalia. Yes, exactly. Fine. So they are malignant cancers. Fine. Now you see here, ductal carcinoma in situ is an anatomical precursor of invasive ductal carcinoma. Fine. That means one day it is going to become an extremely aggressive cancer. Today it is just a small snake. Tomorrow it may become a massively big snake. Fine. Massively big snake. Now, so because it is a small, it's a low grade tumor. So the treatment would be wide local excision only. Wide local excision. Chemotherapy is not required. In place of axillary dissection, what we do is sentinel lymph node biopsy. We'll discuss what is sentinel lymph node biopsy later. Fine. The next thing here which we are going to study is Van Nuy prognostic indicator. So Van Nuy prognostic indicator will tell if we need to use radiotherapy or not. If we used to do factor 5 lead-in mutation, that can be the cause in hypercoagulability and other disorders, but not here. We study that in the deep vein thrombosis. Now you see here, I told you the earlier PPT was not mine. You can see over here there is milk line. Fine. That means polythelia. There could be multiple nipples. Fine. Now you see Poland syndrome. If you can clearly see, the image is not clear. You see on this side, the pectoralis major muscle is absent. Poland syndrome. Now you see this is tennis racket incision. Now this is a common question which they ask. When can the nipple discharge become serious? When you should notice the nipple discharge? If it is a unilateral discharge, that means coming from a single side, single breast. Fine. You see what is the most common cause of bilateral nipple discharge? It is often physiological, milk secretion. Fine. So unilateral nipple discharge should arouse some suspicion. If there is mass, it should arouse suspicion. If the discharge is coming from the male breast, it should arouse suspicion. Fine. It should arouse suspicion. Yes. Fine. spontaneous. See, Shashank, I told you that the most common cause of bloody nipple discharge is a benign tumor. So that is why that is not there in the list. Fine. Now, this bloody discharge, why it is there? Because this is the second most common clinical feature of breast carcinoma. Second most clinical feature of breast carcinoma. Fine. So if there is a bloody nipple discharge coming from single breast, you should ask the patient to undergo clinical examination. You should ask the patient to undergo mammography, ultrasound, whatever you want to convey to the patient. Fine. Now, the question, what question they ask is, what is the difference between multifocal versus multicentric? Fine. You see here, we are discussing about more than 2 tumors in the same breast, more than 2 tumors in the same breast. Now you see here, multifocals mean more than 2 tumors, they are present in the same quadrant, Multicentric means 2 or more than 2 tumors in the different quadrants, Fine. So multifocal versus multicentric. Now you see here, this is carcinoma in situ. You can very well see that this cancer has not breached the basement membrane. Dr. Milmitra Sahu, more than 40 years of age, your patient has chances of development of cancer. Fine. Patient has chances of development of cancer. That is why this discharge is serious. Multifocal. If your patient has 2 or more than 2 tumors in the same quadrant, for example, this is outer upper quadrant, this is inner quadrant, inner upper. Fine. This is inner lower quadrant. This is outer lower quadrant. So you see, all the tumors, they are present in one quadrant. So that will be multifocal. If there are 2 tumors, but they are present in the separate compartments, fine, it will be compartments or quadrants. It will be called as multicentric disease. Now you see here, normal duct. Now you see, this is the basement membrane. This is not breached. Fine. You see here, the cancer cells are here. They are not here. Fine. The red colored basement membrane is not breached. Now you see in the last image, red color basement membrane is breached. Cancer cells have gone beyond. They have gone beyond. Fine. Now, so this is Van Nuy prognostic index. This will tell whether you have to use radiotherapy or not, right? Now, lobular carcinoma in situ is just an increased marker of risk of development of cancer. That means if your patient has lobular carcinoma in situ, your patient has increased risk of developing carcinoma breast. Fine. Now, according to the 8th AJCC classification, it is considered benign disease with risk of malignancy, lobular carcinoma in situ. What is the problem then? The problem is it is often multifocal. Fine. It does not provoke calcification. Fine. So that means it cannot be detected. It cannot be detected by mammography. Fine. So the treatment. Either you give your patient tamoxifen for 5 years, or because your patient says I cannot take it, that I am at the risk of developing cancer, so you offer your patient prophylactic mastectomy. You offer your patient prophylactic mastectomy. Paget disease. So let's say this is the nipple, this is the breast, and this is the duct. Now suppose there is cancer living inside. The cancer cells, they migrate and come out to stay on the nipple. They will destroy the entire nipple. They will destroy the entire nipple, like you can see in this image. They will destroy the entire nipple. Savior in white coat. I'll request you to elaborate later. This might help me in my teaching actually. So you see, here the cancer cells, they have come to stay on the nipple, and you see they have destroyed the entire nipple. They have destroyed the entire nipple. Fine. Now, what they commonly ask is that when we have to compare Paget disease with the eczema of a nipple, you see, eczema of the nipple is skin condition. It occurs in the female who are lactating and their child is not able to take enough of the milk from their breast. So consequently, what will happen is their breast will continue to leak milk. Fine. So Paget disease will be present if the tumor is present. Fine. Eczema will be present if there is milk secretion. Fine. Now, because eczema is a skin condition, there will be marked itching. Because Paget disease is cancer which has come to stay on the nipple and areola. Fine, nipple and areola both. Fine. So that means there will be mild itching only and no vesicles. Nipple will be totally destroyed. Only the skin of the nipple is affected in eczema. That is why nipple will be preserved. Nipple will be preserved. Fine. So, only thing is, if you don't want to remember anything else, just remember eczema will be bilateral, Paget disease will be unilateral. Paget disease will be unilateral. Fine. That's important there. That's important there. Fine. Now, we come to the clinical features of invasive ductal cancer, the most aggressive cancer there, invasive ductal cancer. So the most common clinical feature will be the lump, Second common clinical feature will be nipple discharge. Second most common clinical feature will be the nipple discharge. Now comes the question, now comes the point which you were asking. Now suppose the cancer cells, they reach the lymph nodes. They will block the lymphatics. Fine. They will block the lymphatics. Right. So that will be, just a minute. Pew D orange is blockage of lymphatics by cancer cells, blockage of lymphatics by the cancer cells. Just a minute. Now, PUD orange means the cancer has reached the skin. So that means it is stage B? This was the question which was asked in the last year. This was the question which was asked in the last year. Now, they might ask you that which of the cancer features indicate skin involvement? Which of the cancer features indicate skin involvement? So, pus is the easy mnemonic if they ask you what is skin involvement. So, Q, B, orange is skin involvement, ulceration is skin involvement, satellite nodules is skin involvement. Now, what is satellite nodule? That is cancer and cuirass. Fine. So this can be a common question because they might ask you which of the features define skin involvement and which don't. So dimpling of the retraction of the nipple, they don't come under the category of skin involvement. So this is not skin involvement. B, what is skin involvement by the cancer? Fine. Breast lump can be normal or abnormal, Dr. Sabir. Fine. So you have to do the proper clinical examination. Again, the common question is which of the clinical feature include chest wall fixity? C, fixation to the tumor. This is not chest wall fixation. Fine. But anterior intercostal and ribs. This is chest wall fixation. So, mnemonic there, SIR. Fine. So, SIR is the mnemonic for chest involvement and pus is the mnemonic of skin involvement. Fine. So, if the cancer is fixed to pectoralis major, this is not skin involvement. Fine. Or this is not chest involvement. Fine. If the cancer is fixed to serratus anterior, this is involvement. Now, metastatic features. So, cancer may go to the bones, vertebra. The question which is commonly asked is what kind of secondary tumor? 80% are osteotic. Fine. 20% are osteoblastic. That means they will help in the bone formation. Choppy voice is there. Let me hold the mic and maybe we can do it in a better way. Now I believe my voice would be clear. See, this is cancer and cuirass. Now this is Pew D orange. Now, we're coming to the most important thing over here. That is the staging of the disease. Now, you see here, TNM staging. Yeah, bro, I'm checking on my system. The voice is clear. Let me get it checked. Let me get it checked.
Students, most of them are saying that the voice is choppy. Okay, choppy. I have to check yes, the clear आवाज आ रही है.
Hello. Hello. Audible. 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 जल्दी बताओ. Clear now. It's clear. Okay. It's just a net issue from your side only. ठीक है? From our side, voice is very much clear. As you guys are like clearly audible. Am I clearly audible? Yes. Everything is fine. I think. Start, sir. It's okay. It's okay. Fine.
अरे वो नेट रुक रहा था इस वजह से वॉइस रुकी.
हाँ बीच में था because मेरे को इसमें से clear आ रही थी. Right, so we'll start with the TNM staging, and you see about the TNM staging, only thing is you have to read again and again, again and again. Fine. T1, T2, T3. T1 less than 2 centimeter, T2 2 to 5 centimeter, and T3 more than 5 centimeter. T3 more than 5 centimeter. When we talk about T4, that means any size but chest wall involvement. Fine. Skin. Remember the mnemonic pus. Fine. Or both skin and chest wall involvement, and then it is the inflammatory breast carcinoma. Inflammatory breast carcinoma. So let's call this A, B, C and D. A, B, C and D. Fine. T staging. N staging. Remember, see, N staging is slightly difficult to understand. See here, N staging. So you see, our main type of lymph nodes are axillary and internal mammary. I'll try to make the thing simple for you, as simple as I can. So you see, we have N1, N2, N3 group of lymph nodes. So N1 are the lymph nodes which are manageable, N2 are bad, and N3 are worse. N3 are worse. Fine. So you see here, once we discuss the so N1s, that means the manageable lymph nodes. See, no lymph nodes are good lymph nodes. All the lymph nodes are bad. All the lymph nodes are bad. Bad news for the patient. So N1A is ipsilateral. That means on the same side of the tumor. Mobile. Lymph nodes. Mobile axillary lymph nodes. Fine. Now, N1B is internal mammary lymph nodes. Internal mammary lymph nodes, but they are not clinically apparent. They are not clinically apparent. They are not clinically apparent. Fine. N1C. N1C is both internal and axillary, but they are not clinically apparent. They are not clinically apparent. This not clinically apparent is important. That means when you look for them, only then you find them. Only then you find them. They are not clinically seen. They are not clinically seen. So you see N2A, N2B, N2A, N2B, that is everything same, ipsilateral, axillary lymph nodes, but now they are fixed. Now you see here, in the N1A they were mobile, in the N2A they are fixed to each other. They are fixed to each other. Fine, they are fixed to each other. Fine. Now, in the N2B, what you will see is that now the internal memory lymph nodes are apparent. That means you can see them. That means you can see them. You see, in the N1B, they were not clinically apparent. In the N2B, internal memory, they have become clinically apparent. Clinically apparent. Once we are done reading all of these, we'll compare. So N3A, B and C. N3A, B and C. So this is clavicular. This is supraclavicular. See the different words: infra, supra. Infraclavicular, supraclavicular. Fine. N3B is internal memory. Both apparent. While we change the battery of the mic, please compare all the lymph nodes. Lag today. It's too much lag today. They say they can't hear. Now, is there any voice? Am I audible now? So this is the query of for it's there. I believe we are audible. Don't worry, we'll come. First, you understand the difference between apparent and not apparent. Apparent means the lymph nodes are palpable. That means you can feel them. You can see how big they are, whether they are firm, whether they are hard, whether they are soft. Not apparent means you cannot see them, you cannot feel them. You can only discover them by special test, like biopsy. Yes, Dr. Victory, it will be available. No, they are saying that they cannot listen. Okay, you can. Okay, from the airport you said. See, buddy, we've checked. It's available on our device. We can hear it clearly on our device. Now shall I continue? Because it's clear. Okay. So N1A. Okay, someone of you asked me about the N2A, AK, Dr. AK. You see N1. First you listen to the N1, the most simple lymph nodes. Ipsilateral mobile axillary lymph nodes. Fine. They are apparent. You can feel them. Then internal memory lymph nodes, they are not apparent. You have to discover them by special investigation. Now N1C, both of them, they are not clinically apparent. You have to discover them by special investigation. Fine. Now N2A, now these are apparent, but they are fixed to each other. N2B, they are clinically apparent. So what I'll do is I'll keep on writing on the side the stages which you have to compare. For example, you have to compare N1B with N2B. N1B, that means internal memory but not clinically apparent. Fine. N2B, internal memory are clinically apparent. Internal memory lymph nodes are clinically apparent. You have to compare both of them. Fine. Now, in the N3B, fine, in the N3B, you will see that both internal memory and N3 are clinically apparent. They are clinically apparent. Compare all of them. The question will be from the TNM classification. They will give you that there is a patient with such kind of tumor. Fine. Now, again, we move to the M classification. M classification is simple. M0, that means no metastasis. M1 means there is metastasis to distant organ. Metastasis to a distant organ. Now we'll see one tumor, stage 1 tumor. Fine. So stage 1 tumor will be, that means the tumor which is confined to the breast. That means N0, M0. lymph nodes, no distant organ is involving. Maybe because of this is lagging. So T2 is the stage of manageable lymph nodes. Oh God. Let me check.
Huge lagging, voice is not there. बारिश के कारण हो सकता है। क्या इसको क्लास को नहीं सब प्रेशर नहीं हुआ, मैं कैंसिल पढ़ रहे थे और उसमें बार बच्चे लगातार कॉन्फ्रेंस बोल रहे हैं ह्यूज लैगिंग, और देख रहे होंगे मेरे टाइम से बोल रहे हैं ह्यूज लैगिंग, नो वॉइस से काम मतलब ऐसे तो एकदम स्ट्रेट काम कर दिया ऐसा करके कैसे होगा
Just wait, guys.
Guys, probably because of the rains, we are having internet issues. Fine, so I believe we'll continue with this the next class. We'll continue this in the next class. Meanwhile, we'll share this video. Meanwhile, we'll be sharing this PPT PDF of today's class and yesterday's class also. Fine. We'll share this. Yeah. It's lagging. They're continuously saying. We'll continue in the next class, in the next session, right?
सुनाई दे रहा है? ओ भाई, आ रही है आवाज? जल्दी बताओ, आ रही है? लैग है, पीछे चल रही है थोड़ी सी क्लास, पीछे चल रही है क्लास। आई क्या? चेहरा है या चांद कोई, जुल्फ गनेरी शाम है क्या, सागर जैसी आंखों वाले ये तो बता तेरा नाम है क्या। सुनाई दिया? चलो फिर सर जो है अगली क्लास जल्दी लेंगे, तब तक के लिए अलविदा। 10 विदानियाँ, स्पॉका नोची, पाका पाका। कंटिन्यू कर, स्टक हो रहा है, अगली बार करा देंगे, कल ही करा देंगे, कल या परसों में करा देंगे सर, ठीक है। अभी के लिए बाय बाय। ब्रेस्ट याद करो, ब्रेस्ट जितना करवाया सर ने उतनी ब्रेस्ट याद करो। चलो फिर सर जो है अगली क्लास जल्दी लेंगे, तब तक के लिए अलविदा। 10 विदानियाँ कल कर देंगे, बची हुई थोड़ा सा बचा हुआ ब्रेस्ट में, ठीक है। बिकॉज यू गाइज आर ऑल्सो नॉट कंफर्टेबल, बार बार स्टक हो रहा है ब्रेस्ट, बार बार स्टक हो, किसको मज़ा आता है? ब्रेस्ट बार कॉन्टीन्यूसली लेना चाहते हैं सब लोग, ठीक है। सो सी यू, बाय बाय, टेक केयर।